Okay, 31. One of the following statements about human papillomavirus and hepatitis B virus is true. Okay, answers? All associated with development of urogenital cancers? No. We know hepatitis B causes liver cancer. HPV causes cervical cancer. Vaccines are available for both of them. This is true. They are all treatable with antiviral agents. No, we know HPV has no antiviral agent. All transmissible by respiratory droplets. This is not true. Transplacental. This is not true. So the answer is B. One of the following statements about dengue is true. Start from the bottom. Responds well to antiviral therapy. This is not true. We said there is no specific treatment for dengue. Has not been reported outside Asia and Africa. This is false. Causes hemorrhagic in more than 50%. No. Transmitted by QLEX, not QLEX. Said it's Aedes. And then same family as hepatitis C virus. This is true. Which family is that? Which family is that? So take note of the mosquito. This is QLEX. And we know dengue is Aedes. Okay. Which family? They're in the same family? Flavivirus. Yes. So Flaviviridae family. Okay. Which of the following is true about SARS-CoV-2? Select one. Genetic homology between SARS-CoV and SARS-CoV-2 is less than 50%. It is not. It is actually 80%. So this is false. Mutations in the RNA polymerase gene aid in the virus to escape existing immunity. Remember we said, where does it mutate? The S protein. Okay. Current PCR test only detects about 50% of all positive cases due to mutation in SARS-CoV-2. No, this is not true. 50% is too low. And you know that for PCR, it's high, it has a high sensitivity and is usually the gold standard. Then D, thousands of variants have been reported globally. That is true. This is a third time. Then SARS-CoV-2 has the same affinity for S2 receptors as SARS-CoV. This is not true. So SARS-CoV-2 has a higher affinity. Okay. So it binds more tightly to the S2 receptors. Okay, 34. I'm not seeing your answers on the chart. Which of the following viruses is transmitted by Let me remove this. Phlebotomine sandflies. So, I mean, many people rush to leishmania. We know leishmania, though leishmania is a parasite, so, but it is transmitted by phlebotomine sandflies. But the question here is viruses. So you have to take note. The answer is Toscana virus. Okay. So Rift Valley is mosquito, dengue, Aedes, West Nile. Now West Nile is the one that is transmitted by Culex. West Nile is transmitted by Culex. The rest are Aedes. Rift Valley Aedes, dengue Aedes, Zika Aedes, yellow fever Aedes, but West Nile is Culex. I was looking for this virus when we saw Culex there. So the virus is West Nile virus. Okay. Which of the following mechanisms allow parvovirus B19 to primarily target erythroid progenitor cells in the bone marrow? Answers? I'm seeing A, I'm seeing B, I'm seeing B, B, B. Majority are saying B. Good. High affinity binding to the P antigen on erythroid cells. Viral surface glycoprotein that binds to T cell receptors. No. Production of toxins. Parvovirus does not produce toxins. Direct viral fusion with erythrocytes. It does not just fuse, it requires a receptor. Inhibition of bone marrow stromal cells. No. So viral surface, high affinity binding to the P antigen on erythroid cells. So remember we said the parvovirus will go and bind to the P antigen cell. And this P antigen is found on erythroid cells. Erythroid cells are the cells that have yet to proliferate to the normal RBCs. Okay. 36. When diagnosing fetal infection with parvovirus B19 in a pregnant woman, which test is preferred? Which test is preferred? We had mentioned this. I'm seeing B. When you're choosing a test, we usually choose a test that confirms, okay? Let's start with A. Maternal serum IgM and IgG. So this is pointless because we are looking for fetal infection. So when you do IgM and IgG, this is going to show you maternal infection. Okay? Ultrasound of fetal abnormalities. Yes, we'll see hydrops fetalis in the baby, but will it tell you that this is parvovirus B19? Are you understanding? Okay. When you do ultrasound, you're going to see a swollen baby. That is hydrops fetalis. But now that will not tell you that this is parvovirus B19. This will show you an effect or the complication of parvovirus B19. So that's why B is not an answer. Okay. Fetal blood sampling for PCR. So this is what is usually done. So PCR testing for fetal blood is usually the most accurate method. Okay. Urine analysis. This is going to be relevant. Maternal liver function tests, also irrelevant. Okay. So it was either B or C, but B, ultrasound for fetal abnormalities, this is going to check the effect or the complication of parvovirus B19. So the answer is C. 37. Rotavirus primarily induces diarrhea through D. Good. Did I? Oh, I did not highlight. So disruption of enterocyte absorption function. Yes, so this was very direct. Okay. Rotavirus has a unique structure that is characterized by, as I said, these ones you just have to repeatedly read them so that they stick in your head. But the answer is B. It's usually double-stranded RNA genome. This is it's a fact. You can't. There's no much explanation. Okay. What is the most common route of measles virus infection? Respiratory droplets. Good. So coughing. When you cough, you spread the measles virus. Okay. Good. 40. Which of the following is not considered a common complication of measles? Okay, so measles, pneumonia is there, otitis media is there, encephalitis is there, diarrhea is there. Hemolytic anemia is not there. Okay. Another one that we have not mentioned, we also have conjunctivitis. And then you remember the Koplik spots. Okay. Hepatitis B primarily targets which type of cells in the liver? Hepatocytes. Good. Targets the hepatocytes. These are the cells found in the liver. Okay, number 42. A patient with chronic hepatitis B is most likely to have which marker in their blood? So hepatitis B markers, do you guys know them? This question is quite common. Very common. Markers of hepatitis B, and you guys have to understand it. I want to send a picture on the group so that we follow through. But what is the marker of chronic infection? What is the answer? The answer is B, yes. So Answer is B. So this question is quite common. I've sent a picture on the group. Can you check the group? Also this, you have to know this because they can twist the question, put infectious, they put, okay. Have you seen the picture? Is everyone on that picture? On the WhatsApp group? I hope everyone has seen it. Okay. Let's start. Start with susceptible. So if you're susceptible to getting hepatitis B, you don't have any markers of hepatitis B serology. Immune after infection. So this means you have the infection, but you've developed some immunity. So the marker will be antibodies against HBS, hepatitis B, and then we have anti-HBC, antibodies against the hepatitis B core. When we say HBS, we mean surface antigen. When we say HBC, we mean core antigen, okay? So a marker for immune after infection is anti-HBS. So antibodies against HBS, which is choice A, and anti-HBC. And then immune after vaccination. So you've been vaccinated against hepatitis B. The marker will be anti-HBS. Anti-HBS. So anti-HBS are a marker for you have developed immunity after the infection and after vaccination. And then a marker for acute infection, antigen, hepatitis B surface antigen. It is also a marker for chronic infection. And then the rest, anti-HCV. So it depends. Is it IgM or IgG? If it's IgM, it's a marker of let's start with this one. HBe antibody. HBe antibody, we don't do that. That does not exist. It's usually HBe antigen. If you're following with that picture, HBe antigen is a marker of infectiousness. And then HBV viral load is the most reliable source to get the number of viral copies of HBV. Okay? Remember all the time, IgM is usually acute, IgG is usually chronic. That's how you have to remember. So if here was anti-HAV, IgG, it would be a marker of chronic infection. But since it's IgM, that's the marker of acute infection. Okay?
Hello.
Hello?
Yes, I wanted to ask on the chronic infection. Why is the anti-HBS, that is the antibody core, is it? Sorry, yeah?
Surface.
Core, is that the surface?
S means surface, C means core.
Okay, the second column. That the second column is the surface.
Yes, anti-HBS.
Then the core is which column?
Core anti-HBC. Are you seeing anti-HBC, the third and fourth column?
Yes.
Yes.
Okay, fine.
Does it make sense?
Okay, I wanted to ask you, why should the surface antigen be negative for both acute and chronic?
So you're asking why anti-HBS is negative for chronic and acute infection?
Yes. What is the explanation for that one?
You know, antibodies against HBS, first of all, you have to ask yourself, why are they positive? They are positive in two things. Number one, if you are immunized, because if you're immunized, you'll be producing antibodies against the antigens, isn't it? And number two, when there is complete recovery. When you've had the disease, and you are now recovered, okay? But when you have the disease, will your antibodies be present? Because your antibodies are used to fight the infection, isn't it? But when you're having the disease, your antibodies won't be detected. But after complete recovery or after immunization is when your antibodies will be detected. Okay? Does it make sense?
Yes, it does. Thank you.
So yeah, have you understood? In this question, anti-HBC IgG can also be a marker. Anti-HBC IgG. So yes, because IgG is a marker of chronic infection. IgM is acute infection, yes. So that's why choice C was wrong, because it has said IgM. Okay. Number 43. Which of the following treatments is an antiviral approved for COVID-19? This one we had mentioned. Remdesivir. This is direct. Which is the primary receptor for host for SARS-CoV-2 to initiate infection? We had also mentioned this as we were discussing COVID. S2 inhibitors. Sorry, S2 receptors. Which enzyme is crucial for HSV1 DNA replication within the host cells? Okay, 45. What is the answer for 45? DNA polymerase, good. So HSV1 has its own DNA polymerase. Integrase, no, this is for HIV. Reverse transcriptase, this is for HIV. RNA polymerase, it's not involved. Topoisomerase is used in unwinding, DNA unwinding, but it's not the crucial one. Okay. Which immune cells play a key role in controlling HSV1 infection during reactivation? Answers? The T lymphocytes. So T cells. B lymphocytes. I mean, the work of B lymphocytes is to produce antibodies. Okay. Macrophages, part of the innate immunity, but it won't play a dominant role. Natural killer cells. Natural killer cells basically are used in early response when they're fighting the infection. Dendritic cells also used to initiate immune response, but are not the primary cells. T lymphocytes, especially the cytotoxic T cells, they're the ones that play a key role in controlling the infection. Okay. Which of the following complications is most likely associated with mumps in females? This one you have to know. I have mentioned so many times. Mumps in females, arthritis, very good. And in males?
Orchitis.
Orchitis, good. The rabies virus primarily infects which type of cell in the central nervous system? Neurons, good. I think we have done this. In rabies cases, passive immunization is often used in conjunction with active immunization. What does passive immunization involve? Yes, administration of live attenuated, this is active from there. So if I inject a live attenuated vaccine, I'm going to stimulate your body to produce antibodies against that, isn't it? So that is active, it's not passive. Use of antiviral drugs? No. Administration of a weakened bacterial strain? This is even irrelevant. No, it's not bacterial. Bacterial strain? No. Exposure to low dose of the virus? No, this isn't. So the answer is injection of preformed antibodies. You know, preformed antibodies are antibodies that are going to be made elsewhere. And then I inject you those preformed antibodies so that they go and fight the rabies vaccine. Sorry, they go fight the rabies virus. Okay? You remember when we said for PEP, we use immunoglobulin, rabies immunoglobulin. So that is now the passive immunization. Okay? Have we understood the difference between active and passive? For active, we want your body to produce the immunoglobulins or the antibodies. But for passive, we are giving you the already preformed antibodies. Okay? Number 50, to the following is a characteristic finding in congenital rubella syndrome. I gave you a triad of rubella. What was the triad for congenital rubella? It involved the ears, the eyes, and the heart. What were they? Deafness, that was the first one. The ears, the eyes, it causes cataracts, and the heart, it causes congenital anomaly of the heart. So basically, you'll be born with an anomaly of the heart, which is patent ductus arteriosus, PDA. But for you guys, what you should remember is deafness, eye problem, heart problem, ear problem, eye problem, heart problem. Okay? It does not cause ocular hemorrhage. Ocular hemorrhage is bleeding from the eyes. This is wrong. It causes cataracts. Okay? So if you see congenital rubella syndrome, think of eye, ear, heart. So the following is not a recognized method of adenovirus transmission. We have just done this some minutes ago. What is the answer? D, sexual contact. Good. There's no way I mentioned sexual contact. When you say direct skin contact, so if you have fluids in your skin, you can get it. Okay. In an adenovirus, which of the following is most commonly affected organ symptom in immunocompromised patients? So there is the question, immunocompromised patients. Remember, I even mentioned when I was teaching. Kidney, did I mention kidney? In fact, I didn't say kidney. I mean, I wish bladder was there, but bladder is still not the answer. But remember, I said it causes acute hemorrhagic cystitis in children. But here we're talking about immunocompromised people, people who have things like HIV. Okay, let's eliminate. Liver, did we report any liver symptoms? No. Kidney symptoms? No. Resp, let's leave it. GIT, let's leave it. CNS, did you report any CNS symptoms? No. So it's either C or D. Between C and D? Some are saying D, some are saying C. So if you can remember, I said adenovirus is usually self-limiting in that you get the virus and then the next day or a few days, you're okay. But the most common, remember I said the most common infection adenovirus causes is gastroenteritis. Serotype 31, 40, and 41. That's what I mentioned. But now in immunocompromised patients, patients who are living with HIV, the immune system is low, it will now cause RESP symptoms. That is the most common one that it will affect them, which is pneumonia. But in healthy patients, the most common is gastroenteritis, which would be gastrointestinal system. Okay. Okay. Which statement regarding the clinical features of shingles is false? E. The rash is usually bilateral, affecting both sides of the body. Good. Rash follows a dermatomal distribution. Yes, this is true. So a certain dermatome. So if it's, let's say dermatome T12, it will affect T12. If it's C1, C1. Pain usually typically precedes the rash by several days. This is true. Remember the pain, we said it's burning, tingling sensation, okay? And it's usually there before the rash appears. The rash usually resolves within a few weeks. That is true. And then shingles can cause post-hepatic neuralgia in elderly patients. That is also true. Remember, we talked about herpes zoster, ophthalmicus, herpes zoster, oticus. So it can affect the eye, it can affect the ear, but it never crosses the midline. Never. If this is a face of someone, draw. We said if this is a face of someone, it will never cross to this other side. It only affects this side. Okay? Never crosses the midline. Okay. What is the main factor contributing to seasonal increase in rhinovirus infection during colder months? Increased exposure to outdoor allergens. This is wrong. When it's cold, for example, right now it's cold, you'll see an increase in rhinovirus infection. So it cannot be the allergens because we stay indoors. Decreased air humidity, which leads to virus survival and transmission. Is this the main factor? Answers. This is wrong. Answers. I'm seeing E. I'm seeing E, I'm seeing D. Hand hygiene. Less frequent hand washing and hygiene practice in colder climates. This is wrong. Lower temperatures favoring the replication of the virus in the nasal epithelium. So I can understand why you pick D, but that's not the answer. So how you guys should understand is lower temperatures, yes, they favor replication of the virus in the nasal mucosa by when you lower the temperatures, what happens is, what are the main ways viruses are excreted out of the body? Number one is we have mucus, isn't it? So presence of mucus on the nasal areas. Number two, we have the hair. We call them cilia. They waft the virus away from the respiratory system. Another one is coughing. By coughing, you're removing the virus, isn't it? But now, what happens during the colder months, like right now or July, is there's lower temperature. So when there's lower temperature, it really doesn't affect production of mucus or functioning of the functioning of the hair. Okay, so it's not really a direct correlation, but I mean, some studies have shown that, you know, during cold times, there is how will I say it? Less mucus production, but it's not actually true. The mucus will be there, but not as normal. It will be maybe reduced compared to when you're during the like hotter months, isn't it? So that's why I want to say D can be true, but it's not really the main factor. And it doesn't really play the vital role to the viral stability, okay? So have you understood why D is not the answer? So the answer is E, increased indoor crowding and close contact in winter months or in cold months. Okay. Number 55, which of the following clinical features is least likely to be seen in a patient with classical dengue fever? So fever, obviously, it will be there. Retroorbital headache, so you can have headache, rashes. Remember, why do you have petechial rashes? Because they're bleeding. And when you bleed, you're using your platelets. And when you have low platelets in blood, there'll be petechial rash and bleeding tendencies. Painful muscle and joint pain, this is true. Hepatomegaly is not seen. Okay, so the answer is E. Number 56. All the following are characteristic clinical features of poliomyelitis except. Yeah, true. Involvement of both upper and lower motor neurons, it does not. So you remember from your anatomy, upper motor neurons, let's say they're from the brain to where it will synapse, and then lower motor neurons is from where it will synapse. So if it's synapsing at the muscle, so okay, let's say it's synapse at the, use any spinal cord. So from the spinal cord to the muscle, so that's the lower motor neuron. So it usually affects lower motor neuron. That's why we have paralysis as a feature, but it never affects the upper motor neuron, okay? The other choices, sudden onset of asymmetric limb weakness, that is true. High fever and headache at the onset, which is also true. Usually at the early phase of polio. Paralysis often occurring in a flaccid manner. Yes, flaccid paralysis. It's actually the hallmark of polio. Muscle atrophy developing within days of muscle paralysis. Yes. So from the use-disuse theory, we know that if you don't use a muscle, it atrophies. It becomes smaller and weaker. Okay. The most critical factor in preventing the spread of polio in a population is, this is very direct, vaccination. Okay. That's why you'll see when you walk around town or your estates, you're going to see some posters have been put there. Vaccinate your children, vaccinate, vaccinate. All the following are complications with congenital Zika virus infection, except we know the hallmark is microcephaly. Developmental delays, yes. So if you get microcephaly. Retinal damage and chorioretinitis, yes. Hearing loss and seizures, yes. So it doesn't cause hypertension. How? Okay. The primary vector of yellow fever transmission is, this one we have said, it's Aedes. We've said Culex is West Nile. Anopheles, Nyong. ticks, and sandflies. Sandflies, we've said Toscana. Then ticks, remember Crimean Congo. Okay. And then the last one, which of the following statements about HIV pathophysiology is false? You guys tell me. Number 60. C. True. HIV targets CD4 T cells. This is true. HIV integrates its RNA to the host DNA using reverse transcriptase. That is true. HIV replication is most active in the CNS early in infection. This is wrong. It's usually late. By the time you have CNS manifestations of HIV, that is late. Later. Okay. HIV virus. So the most active is the blood, I mean, where your CD4 cells are found. So blood and lymphoid tissues is where is going to be the active one in the early stage of the infection. HIV virus binds to CD4 receptor and CCR5 or CXCR4 co-receptor on the host cell. That is true. Chronic HIV leads to progressive depletion of CD4 cells, resulting in immune dysfunction. That is also true.